I am very excited to welcome you to this evening's event, our community listening session on mental health care in Multnomah County. It's hard to believe, actually, that we were worried that we weren't going to get enough turnout for this event. This amazing turnout here tonight just reconfirms for me how important this work is and why we need to be doing this. So I'm Sharon Meieran. I am the Multnomah County Commissioner for District 1. That includes all of the west side and inner southeast out to Chavez or 39th. But I do consider all of the county my district. This issue is important to all of the county, to all of the state, to all of our country. At the county, we oversee the health and human services and much of the public safety in the county, but I'm also an ER doctor. And as an emergency physician, I too often see people experiencing mental health crises who don't have anywhere to go for help. One of the main reasons that I actually ran for this office is because of what I see in the ER and to improve what I perceived as a fragmented and often, I'm sorry to say, dysfunctional system of mental health care delivery. Multnomah County is one of the largest safety net providers in health and mental health care in the state of Oregon. And mental health care is particularly challenging for a number of reasons. First, funding comes from a variety of sources and doesn't necessarily follow people, but follows, I don't even know what it follows or where it goes. Multiple organizations provide care at multiple different levels, and they don't often necessarily talk to one another. And health reform continues to change our landscape. But despite the fact that really great people and organizations, many of whom are represented here tonight in this room, are doing really fantastic work, the reality is that accessible and effective mental health care remains elusive. Too often people end up in crisis, in the emergency department, in jail, or on the street. And too often our systems don't seem to work together, which is what really gets to me, as effectively as they could or should. And there are gaps that result in people falling through the cracks. So to make real meaningful change within our sadly limited budget, what we're doing is undertaking a deep systems analysis of the county's mental health system, how it currently exists, because people, each system has its own idea kind of what it does, but not how they interconnect, and they do interconnect. So this analysis will build on previous studies that have been done. So if you're thinking, oh, we've already gone through, we've done a study in this department or this department, we will be aware of that. We will follow up on those. We will take that into account. It will also focus on the touch points between systems where people often get lost. And it will examine funding and reimbursement mechanisms to better understand how the services we provide are paid for. So that last piece is important because we can come up with all the best ideas in the world, and hopefully tonight we will come up with some of those ideas. I know some of you have already come up with great ideas, but unless we can figure out how to pay for them, they will sit on a shelf or in our minds, and that is not what I want. I want to learn as much as we can so we can actually take concrete steps to make changes to our system. I want to actually take action. So to help us, action, good. So to help us do this systems analysis, we have hired Human Services Research I'm so bad with they're so amazing. But Human Services Research Institute, or HSRI. They are a health and human services policy and research firm that has had strong expertise in assessing behavioral health systems at the state and county levels. They'll be talking to you next and telling you some about their background and what tonight's program will look like. But one last thing quickly before we get started. I want to make sure you know that tonight is not the only time to get involved. It is a great start. I'm glad you are all here. And we want to hear about your experiences with and your ideas and vision for the future of our mental health system. There's a form on our website to provide information. Please share this form widely with your networks. Fill it out, even if you're talking here today. We also are considering additional ways to hear from people in the coming months. I will keep you posted through my newsletter, and hopefully you've agreed to sign up for that. A lot of you who RSVP'd or provided your emails here, I will send you the newsletter because it will provide updates about what I'm doing. If you do not want to get that, just let us know and we will get you off of it. But it will have important information. So, and finally, the last thing I really want you to know that the most important piece of this whole process is all of you here today. This is called a community listening session, not so the community can listen to us, but so we can actually listen to the community. You are the experts. You experience the system. We try to do the right thing, but you know how that plays out in the real world. These are difficult issues, have impacted many of us very deeply. It takes courage to be here this evening. So I just want to say, end with one of my favorite quotes, which is something I take to heart because it's still hard for me to speak in public. But it's speak your mind even if your voice shakes. So I am just so glad that you're all here today. We have a tight timeline. So without further ado, it's my pleasure to introduce you to Bevan Croft, the lead researcher for the HSRI team. So thank you again for being here.
Thank you, Commissioner Meieran, and hi everyone. It's really fantastic to see such a turnout, such clear and obvious interest in participating in this process. We couldn't be more pleased with the numbers here and the participation in this room. So thanks for showing up. As Commissioner Meieran said, we have a packed evening, so I'll just spend a little bit of time orienting you to kind of how the discussion is going to go this evening, and we'll just kind of soldier on. The idea and the goal of this listening session is to really be systematic about hearing from as many people as possible in the community, all right? So we've sort of set up the meeting so that we can do our best to make sure that each of you, in the perspective that you bring, is reflected through this process. So here's how it'll go. I'll spend a little bit of time just orienting you to the project a little bit more, describing our aims and some of the methods that we'll be using in addition to this listening session to do our work. And then we'll break up. I think we'll be able to stay in the same room. If there had been like a couple more people, we might have had to go up into the overflow room, but hopefully this is us and we can stay cozy. But basically we'll be breaking into groups based on these tables here, and there may need to be some shuffling around, and we'll discuss a couple of questions in smaller groups. It'll be loud, but we'll do our best to make it work. And then we'll come back and have a group discussion, and I'll get into a little more detail about how that'll go, but that's the basic idea, and we'll have a quick break in between because this is a couple-hour meeting, and then do a quick wrap-up summary and talk about next steps. So first, Linda, if you could go to the next slide. Just a little bit about HSRI. So we have offices here in Tualatin, Oregon, and then also in Cambridge, Massachusetts, and we're a nonprofit organization that's been around about 40 years. We just had our 40-year anniversary last year, and we have a number of different teams across the human services field, in the fields of intellectual and developmental disabilities, child welfare, aging and disability, health data, and then I sit, and my team and I are on the behavioral health team with expertise in mental health services and also substance use disorder treatment and prevention. So we do research, evaluation, and systems planning work with a number of different states, counties, and other jurisdictions around the world. And we use research methods. We are a data-driven organization, but we're also a values-based organization. We believe in the principles of nothing about us without us. We use participatory methods whenever possible, and we really seek to ensure that people with lived experience are engaged early and often throughout the process, from seeking information from communities to interpreting the data to creating reports and materials that are written in a way that people with lived experience, policymakers, providers, stakeholders across the spectrum can use the materials effectively to make change in their systems and in their different roles. Our project team is led by me, along with Linda Newton-Curtis, David Hughes, and Martha Barbone. And we also have a number of other folks from HSRI here to help out with note-taking this evening. So these are our study aims, and really there are four. The first is just to develop an inventory and to really map out the resources that are currently available in the community. And to also map not just the resources, this isn't just a static list of services that are available. You already have those. There are actually 3 or 4 that we've seen already. But to look at the connections between those resources. And then to see how resources and communication flow between those resources, those mental health resources, but also between the mental health system and adjacent systems, because we know that those systems are also important for people who use mental health services, criminal justice, education, child welfare, and on and on. And then finally, to identify gaps and points of weakness and places where people fall through the cracks. And this exploration is systematic. So our methods, I believe, are on the next slide. Yes, so 3 primary areas. One is listening to the community here, gathering feedback from the community to understand what they identify as strengths, needs, aspirations, what does the system look like? We are also sitting down with key informants from around the system. Key informants are people who have a particular perspective on mental health services in the community, including, importantly, people with lived experience of using those services and their family members, also providers, administrators, representatives from criminal justice, again, all those different adjacent systems as well. So we'll be conducting those interviews this month, next month, trying to do as many in person as possible, but some will be by phone, and those interviews are recorded and summarized, and we'll be using qualitative research methods to sort the information into themes in a systematic way. And then finally, as Commissioner Meieran noted, we recognize that there have been plenty of work groups and reports and committees and different teams, many of which have focused on specific facets of the mental health system. And our goal is to identify those reports, synthesize them, build on them, not reinvent any wheels, but really bring together disparate information in a way that makes sense to tell a story and paint a picture of the system as a whole. So here's how this evening is going to go. In just a moment, we'll break out into discussion and into groups.
Hello, folks. I am Reverend Luke Walters. I represent Oregon Consumer Advisory Council, and I sit with PAMI, Protection and Advocacy for Individuals with Mental Illness, Advising Disability Rights of Oregon, and then some. So we had a very great conversation and touched upon a lot of awesome topics. The most pressing difficulties facing the mental health community today seem to us to be difficulty accessing services, long wait lists, difficulty with following up with folks, determining whether the issue that they're having is basic lack of basic needs, or whether it's a mental health condition that they can't really address because they've got all these basic needs that aren't being met, and then keeping their interest, because if they wait too long, they're just gonna walk out the door and might not come back anytime soon. So a lot of really big issues right now. My piece that I shared was, it seems that the lived experience, the peer delivered service role, has still a ways to come to where it's like equally integrated into the system, and there's value and respect and equality in wages and influence in the workforce, and really understanding about what that piece is and the value. So if we have that and a system designed by peers that have lived through the experience or with peers at the table helping to design these systems, that would be a huge, huge improvement. What we saw for a vision of 5 years would be perhaps like more integration and ability to have Medicaid funding, which seems like a big piece. And what I'm really excited about is having the outreach teams be able to get out there and go where individuals with mental health conditions reside in their villages and engage them directly rather than waiting for them to come to the agencies, the offices. And then from there, helping with a seamless progression of services integrated. I'm thinking through the certified community behavioral health clinics. It's kind of a new thing, but it seems like a good idea. And then can connect with like respite housing, longer term housing, even peer farming in rural areas, which have the ability to have longer term, like larger accommodations, you know. So it's really exciting what we're coming to, and lots of people at the table interested in solutions.
Hi, Keven Makdessi. So in terms of problems, I will try and do this as bullets because there are a lot of them. So the one of the issues was, or one of the problems is older adults with both health and mental health issues, and the inability to get care for both issues at the same time. Also, there's a need for more outreach. So there are a lot of people that fall through the cracks. And then private insurance is actually an obstacle in most cases to getting behavioral health care rather than a help. There are too few psychiatrists who will take on people that maybe have Medicare or Medicaid or even private insurance. There's an inconsistency and lack of knowledge within the actual treatment field, so that there are people who are not able to refer people to the right resources. Also silos, so that you may not be able to get referrals from one system to another. For instance, the behavioral health system to APD. And then the use of jails is sort of the last resort for treatment services. They're not equipped for that, and probably never will be. And then the another big issue is also just the period of time between somebody moving from or being discharged from one level of care and being able to get an appointment for care at another level. And there's no case management for those people during that transition period. And also not enough supports to help people live independently. So vision. Actually, it was suggested that there be a neighborhood center for each neighborhood association that would provide services to people in a comprehensive way, or at least get them linkages to services that they need. Also, no wrong door. So wherever you choose to get help, you get a comprehensive assessment, and you get referred to services in a timely fashion. And that assessment and that plan of care follows you wherever you go after that. So you don't get a new plan every time you go to a different provider. We'd love to see a single payer system. So it didn't matter. It didn't matter what your insurance was. So you could get help no matter where you went to get it. A lot more services for access for youth. Certainly a more focus on rehabilitation and a maximum effort to divert as many people as possible from the criminal justice system. And then also decriminalization and destigmatization of both substance use and mental health.
So my name's Joan. I'm a social worker, but I'm going to try not to color the presentation with my perspective. In addition to what the prior groups have already talked about, our group was sort of more focused on people living outside. We talked about this kind of cycle and relationship between mental illness and addiction, homelessness, prison, and that sort of cycle. We talked about the chronic homelessness and that sleeping outside means no rest for someone who's mentally ill, access to medications and holding on to medications when you're living outside, when you're staying outside is really difficult. Access to medications, period, can be hard for the reasons that were already stated, all about insurance and getting able to see doctors. We talked about the lack of culturally congruent services. So services for all diverse people is just not available. If even the housing that's available, even if it were accessible, it's not necessarily appropriate. SROs that don't have kitchens, sometimes shared bathrooms, all downtown, very traumatic setting, a lot of drug use, a lot of activity, a lot of criminal activity. It's not a great place, and also often full of other mentally ill people, so they're all just kind of being warehoused together. It's not really healthy. We talked about the lack of services in general. Services for veterans, whether they're honorably or dishonorably discharged, are very hard to come by. And high intensity wraparound treatment services in the community, like ACT program, they're actually reducing beds this year rather than adding. We really need more of that. And the very precarious state hospital discharges to the street after spending 6 months in a state psychiatric hospital with very little planning. Lack of trauma-informed care as well. And a very good point was made about the Unity Hospital being a consortium of local hospitals that are now kind of strangleholding that and the access to that service. So since Unity is the only game in town at this point. And that's kind of the problems. Oh, and the correctional facilities being, actually it's a first place where they send mentally ill. It's not a last resort, first resort. So we talked about appropriate and sustainable housing and services, better services for children and families. So with preventative services starting early in the stages in the disease process so that it doesn't have to get to the point where it's completely unmanageable. Expanded mental health court system and training for police. Yeah, I agree. Involving families in care. Increased outreach workers in a general way, community workers, just putting a lot of money and funds into that so that people can be out in the community. Cultural training for healthcare providers. Cross-training for all mental health care providers in addiction, please, so that we can understand the cycle between mental health and addiction. And education for the public to diminish the stigma of the mentally ill.
When we talked about our vision for improved service in the future, it looked very much like the system we have now with tremendous improvements. We have some, we're not on? Okay. We have quite a broad spectrum of folks at this table, and I'm sorry, I'm trying to get distance right here. Is this it? Okay, there we go. So again, with the folks that are getting caught up in law enforcement for treatment as a first resort, this happens every day. certainly for our vision for the future is something that looks different than what we've got today, so that there's more off-ramps, so that people don't end up in the state hospitals and in law enforcement and in custody receiving inappropriate services and collecting charges while they wait for a discharge planning and so forth. We have an individual at our table who had a very specific experience that she wanted to share, and so I was going to let her have an opportunity.
Hi, my name's Laura Idika, and I've been involved in the mental health system for 28 years now. I've had multiple, probably 20 to 30 hospitalizations for suicidal ideation. One of the things I really stressed to these wonderful people who were so loving and accepting and encouraging of me to share is that I feel the healthcare system in the past was more people-oriented. I felt more support. I felt more encouraged. I feel now everything boils down to money, funds. I had to fight to get my disability back for 5 years, 2 hearings, 3 in-person interviews, 2 different lawyers, because I had been on it for 8 years and then worked in that Ticket to Work program and lost it 2 years later after I'd been hospitalized, after a hip replacement. So the system, I really fell through cracks. The peer support is something I go to Old Town Clinic and I love it. The peer support is something that's really beneficial, especially in the living room downstairs, which is like a drop-in center for us. But we're all welcomed and encouraged to be a part of it. I do want to say that I've had really negative experiences in some agencies, and I don't want to put them down, but I feel that my help through Cascadia was not real helpful. I lived in an apartment for 3.5 years and kept saying I needed a clean and sober living, clean and sober living. I can't do this here. I take responsibility for my own addiction issues, but living with other chronically mentally ill who came out and said they were God or Jesus and, addiction issues, it was just really difficult. And I did not get that help. I am now homeless again, and it's taken this for me to get my stuff together. Old Town Clinic has been a huge part. And one of the reasons I think they're so beneficial is the whole mind, body, soul that is part of their philosophy. Dr. Shapiro is an awesome man, and he's incorporated spirituality in our groups as a drop-in center. It's amazing. They offer so many services, and I find a lot of the people there are just very compassionate. My thing is wanting empathy, not sympathy.
Things that stood out for us would be the branding or rebranding of the stigma of mental health or mental wellness. Families, keeping families together, providing them with skills to manage symptoms in their own home rather than splitting families apart, sending children over to here or a parent over to their different agencies. Funding programs for long-term care rather than 1 or 2 years and then the program lose its funding and then the families have to go somewhere else. So that would come possibly with a flexibility of collaboration of funding streams to fund one program for multiple years. And then a singular location where an individual can find aid for multiple complex needs, kind of in a generic term as a one-stop shop. Like I go to Les Schwab and I can get a lot of things done there, but a person has to travel over all of God's green Multnomah County to get their things taken care of.
For the most pressing issue, our theme was that the system is extremely difficult to navigate, especially even if you have your wits about you and you've got money and you've got time, it's still difficult to navigate. And the large access points in the system, like aging and disability and OHP, are not trauma-informed for people working with mental health issues, or a lack of phone minutes for that matter. And also, the lack of stable housing, it perpetuates all the problems we see, like people living with dual diagnosis and substance use disorders with their mental health issues, and just the lack of places like respite care for people to go and recover when they hit those points of, extreme psychosis or extreme distress. So in 5 years, what is our vision? So definitely more interconnectedness between systems, more peer support specialists. It's an underutilized, wonderful way of doing things. We see great results, yet I think I really agree with the group number one is that the peer role isn't as valued as it should be, and it isn't as recognized as being as valuable as it is. Let's see, and so increased coverage for people with Medicare. We see a lot of people who get switch over to Medicare after being 2 years on disability or hitting 65, and then there goes their mental health services. It seems a very backwards way of approaching that. When a person gets sicker and older, we take away their services. I don't get it. And then I want to make sure I get all the good things. Just a more understanding from the community, more programs around employment, housing providers, people kind of all in, more community buy-in and making it work for people. This is a community-wide issue. Everyone knows someone struggling or seen people outside struggling with these issues, and it's going to take all of us to kind of be willing to open our minds to how we help these folks. So.
Hi, my name is Katrina, and this is my new friend, Kathleen. She and I have both experience living on the street, and also Central City helped me gain housing and whatnot. So big props to them. But in the next 5 years, I hope to just see those systems expand. As far as I'm concerned, what's in place was extremely helpful, and I just want to see more of it. That and more attention to the crazy meth heads that are on the street, because I think that's what ends up being a huge problem is A, the meth epidemic, and B, not quite knowing what to do with those people that are going crazy and yelling and committing crimes or hurting people because they're strung out on this drug that destroys their body. So that's one thing I would like to have attention paid to somehow, or more. I don't know if you can have sensitivity training about meth use, but you know, that's what I see as the biggest issue among homeless people, honestly.
I am a native Portland, Oregonian of 50 years. I have owned various businesses in Portland, and for one reason or another, I now live at the Salvation Army Safes House, which is a homeless shelter for women and transgendered. And Katrina brought me here. I met her because of the mental illness issue. And I'm glad that there are people here that are thinking about it, that are empathetic to it, and are hopefully going to be looking at what you're doing tonight and ultimately finding an action plan. I see that we're talking a lot about things, and the goal later is to get into group discussions and see what your visions are of these things. But I'm telling you right now, action can be done, and it really can be done while looking for your vision. I mean, even this evening, if you don't eat all the pizza, would you be willing to let me take it down to the Salvation Army safes and the salad? There's a room full of 50 women there that would with no food, that would greatly appreciate that. And also, I would like to ask that the next homeless person you see that asks you for $1 to say hello, and would you please give them something? Just give them $1. Or I ask that you prepare this, find a coin, and put that in there, and that'll help you think of your vision. Okay, and then when that person does it, because it's going to happen, you can't go to Target. I can't walk out here and walk down to the bus stop. You could, but I ask. That's all I ask. So you can take action and continue with your vision.
My name's Haven. I'm with Lukedorf. I was not the original leader for this group, but we had a few people who needed to leave. So I will try to kind of wrap it up to what was unique to this group, because we covered a lot of the same things that we've heard so far. And the key themes that I really heard were culturally specific services and really thinking about the needs of refugees and immigrants within that, and some of the barriers like language that come up and make it difficult to navigate systems and may influence the way that folks are treated by systems in ways that can be really re-traumatizing. And thinking about what does training look like for frontline staff, and what kind of awareness of intergenerational trauma and how that can play out is present. And another piece, as you might guess, is trauma-informed care, and really looking at how that's interwoven. I've heard that before, and where our group really took it was looking at flexibility and flexibility of services and whole person, and how can we really provide services that are going to be effective within a rigid system. And right now the system's really rigid, and what is billable is really rigid, and what people need is often really flexible and does not fit within those boxes. And part of that is peer-delivered services. Peer-delivered services are amazing, and they're really undervalued, and a lot of people don't even really know what they are. Even folks who are working in the field don't understand the magic of what peer-delivered services can truly provide, in part because it's hard to find a well-structured program, which again goes back to funding. And there was a really great example, because we also talked about how to meet the needs of folks who are houseless. And it may be really difficult for them to come to a clinic and attend sessions in a really structured way. And so having things like outreach, but then also looking at, as we're looking at the issue of housing, being flexible and thinking outside the box about how we meet people where they're at. And there was a really cool idea that I heard of taking the folks who are already living in some of our wilderness areas that we're trying to really keep pristine and renew, and actually take the folks who are living there, and rather than continuously trying to drive them out and bringing in other people to clean up, why not try to work with folks who are living there and figure out if they might be interested in being part of keeping that space well put together.
Hello, my name is Fred. I'm an emergency physician for Kaiser, and I'm also married to Sharon Meieran. And we had thank you, we had a great group. I'm just gonna, and I think all these things have been mentioned already, so I'm just gonna put out kind of a laundry list of the challenges. And the first at our list was affordable housing, access to outpatient substance abuse for people with dual diagnoses, the lack of child services that are small, fragmented, and limited right now, insurance limits, especially with the way that medical versus mental health and substance abuse is treated now, that there's time limits for care and housing, that there's too much oversight and really not sufficient providers that are on the front line, and also the criminalization of mental illness. And so our 5-year vision is a client-focused system of improved access with better communication between programs, with better coordination between systems of mental health, substance abuse, homelessness, housing, and the jail system, and with funding for transition between these programs and systems, with more emphasis on preventive services and less on the chaotic reactive services, with adequate supportive affordable housing, with special attention to cultural specific needs and youth and child services and programs, with increased use of peer-delivered services of people with lived experiences. There was a suggestion to close the state hospital, with an ability to bring the services to the clients, and adequate funding for all of this. And so in short, actually I think the first thing that was said at our group, really kind of summed it up, is that the vision that all Multnomah County citizens with mental health needs have the recovery, hopes, and dreams met for a better quality of life.
First thing is safe, warm, and dry housing. Shelters, smaller shelters, these 200-bed shelters don't work. 16 people, maybe a little bit more. Safer, specialized shelters for people with mental health issues. Always empty beds in Portland. So see somebody on the street, we have an empty bed for you. And stable housing. Navigators, both volunteer and hired, to caseworkers who are experienced, people who can can go to people on the street and navigate them through the system. Multiple points of access from church, prison, other points. Does that sound okay? Reduce wait, I put this one in, reduce wait times and coordinate with medication. Some people are waiting, 60 days for to get into something, and they only have 30 days of meds to get them through it. And consumers and citizens and first responders, police who are educated and understand mental health issues. So a community-wide education program.
Hi, my name is Zahra Adam. I work at AERCO, and I'm a community health worker. We talked about immigrants and refugee community a lot. And what people don't know, that the refugees, when they come to the country, they have only 8 months period to get into OHP, and they can access mental health as well as other medical services, while immigrants, the people who come with the green card to this country, they are not even qualified for any kind of insurance. So they don't really have any access, and if they have mental health, and they can't really access any of these healthcare providers, then the problem is gonna get even worse, because a lot of people, they come with a lot of trauma and they have PTSD. They've been going through a lot of life transitions, and they come to this new country and they can't even access any healthcare or any mental health providers. So we talked about that. We talked about a lot of barriers, and the most common barriers is the communications. Translation, interpretation to other languages is not provided. Most of the time people go and get, English, Spanish. So if you don't speak Spanish and you don't speak English, you don't really have, the material that you can access and understand or distribute this information to your own community. We talked also. We also talked about separating the criminal justice from the mental health field, because they are not exactly related. And we talked a lot about the accessing the crisis through the ER is not also a way to provide good mental health services, because they don't really have enough empathy for people at the ERs. The vision, we have triage, we have we have to have some sort of system in the jail to be in place, so that people can get access to diagnoses and whatever that they need to be seen for while they are in jail. We also talked about having more workshops, community educational session to different communities in different languages, and provide different trainings that is culturally appropriate, because each community, they have different needs. And even if we are talking about mental health, each community and each person, they have a very different case, so they are not all on the same page. So I think we talked about prevention, and that's also a lot of things that people were talking on our table about it, and we think that it should be okay. So we thought about the alternative way, the natural way, and natural remedies to help people with mental health overcome their problems. A lot of times people have a simple, depression or stress or anxiety case, and then they go and get treatment, medication. Then the medication will mess up something else, and then they get more medication, especially if they are refugees and immigrants, because I come from a refugee and immigrant organization and a community. We don't really have the ability, the body does not really have the ability to digest to this chemicals and all medication that they've been prescribed by their provider. So we talked about how about the natural approach, helping people to overcome their barriers, whether it's anxiety or depression or whatever it is, and help the people to be more healthy. Even if you change your diet and your food, that will reflect on your mental health system. So how about, these ways, invent more on this approach rather than only the medication. And we'd like to see everybody in Multnomah County within 5 years absolutely covered or have an access to health care. If they don't have OHP or they don't have private insurance, then we would like to have a place where these people with no insurance, they can still be seen when they have mental health needs.
I'm Charles Bridge Crane Johnson, and I guess I was sort of nominated as a most recent lived experience because, oh look, 12 hours ago, BHU, Behavioral Health Unit, is an acronym that also applies to our police department. So Miss McKay from the BHU was escorting me across Irving Street, 650 Irving Street, to an ambulance. So the time and labor of 3 police officers was being engaged with 2 paramedics to put me in a ambulance that's going to go to Unity, right? Because that's where no, status red, Unity's full. Because it's a really, which nobody should be surprised about. Every half-sane person that had no cold weather shelter on Friday and no cold weather shelter on Thursday night knows that they're not crazy. They're in need of services, and Unity is the only place that's got a bed for them that night. Then next night, the shelter's open, so I stay at Imago Dei. What we do to homeless people with mental illnesses is we tell them, if you don't come in every week and renew yourself on the list, just die. So I show up on Monday morning to sign up on the list. Oh, we didn't reset the list. The hour you spent coming through here, plus the time through the cold, just do that again tomorrow. So I got service provision from 3 police officers, 2 paramedics, and the nice people at Good Samaritan Hospital, the new little 3 special cells that are set off from the rest of the regular emergency room. The reason I'm focusing on my personal story is because it's not unique, as we could hear from the various reactions around the room. TPI, perhaps the highest anxiety, most distressing place for mentally health people to spend their day, has 0 peers, 0 license, there's no care professional de-escalation intervention going on there. In a sane system, we would have engineered some capacity maybe at Central City or somewhere else, and if I wasn't safe to walk there by myself, I could have been escorted at a much lower taxpayer impact than 3 police officers, 2 paramedics, and an ambulance. And I'm engaged with these people. Stuart Evans has known me for a year. Kevin, Sharon Meieran has to put up with me almost every week of the year since she did that foolish thing and got elected. How much more suffering is going on there for people who are not white middle class, not necessarily straight men that didn't come from Dave Stockman, Republican white America, and have much greater barriers and challenges, as the woman just mentioned, interfacing with a system that has good people, but have probably been conditioned to provide services to people with a similar middle class and language background. So the reason I keep harping on the 3 police officers with 2 police cars going to 1 ambulance is all those things cost money. Money that would have been better spent making some underpaid but paid peers available in the Old Town Chinatown. How many are there permanently available there? Well, 0. We have a Central City person here, and so they have some people with that. In certain areas, they begin to qualify for and be able to initiate some peer-based services, but they only have a little teeny drop of money compared to what the police department has. And we need to, when we do this project with HRSI, we need to think about those monetary impacts and that it's totally legit to say, oh, we're not going to have the police do as much mental health responding as we've been gearing them up for 5 years. We're going to cut their budget and fund some peers.
Our most pressing issues that we kind of all agreed on, and we had people that have experienced the system from within. We've had employees that have worked there, and then we've had resources for the employees. And then we had me, who my mom died 9 months after getting out from under the PSRB 7 years ago. So the most pressing issues, funding, obviously, the caseload, but also basically a system that really for the people that have to use it feels like it's meant to keep them there and not to help get them out. So pressing issues like not having access to resources outside of crisis, which includes learning things like even how to vote so that you can vote for people that really have your best interest in mind. Which will come with kind of educating. And so care coordination came up, consistency of care. And our vision for the next 5 years was things like this, a more open forum for clients, frontline workers, management, to expose, address, and overcome obstacles. And then just education for families. My mom died 9 months and she had a place to live when she got out. And I cannot imagine what it would be like for other people. So really just coming up with community systems to better educate the community so that even if the funding doesn't come, we can still deal with this issue. And so transparency within the system, we think would help that to encourage people who are going through these crises to seek help because they feel like they'll be listened to. And that they'll be able to get alternative treatments outside of just medicine, and have coping skills to deal with life when you don't have any other resources.
I didn't really have anything to say except I just want to, my name is Kevon Fitz, the Oregon Mental Health Consumers Association. I just want to give a shout out and thanks to Commissioner Meieran and her staff for putting this all together and hearing what the community had to say.
My name is Silvia Zynga, sir, and I'm with NAMI, Multnomah. I have a son who is mentally ill, and he has gone through being picked up by the police. He's suicidal, and so we've gone through several phases of that. The thing that I am concerned about and really wanted to bring to the forefront is that he's a big guy, and so they have sedated him, and by the time they get him into the emergency room, this was at well, actually, it's been OHSU, it's been at Adventist, it's been up at the VA, he's a vet. He has to be intubated, and nobody can really tell me why he has to be intubated. My concern is that he has been sedated at the time he's been put in to the ambulance. And so I have called AMR twice to talk to them, and no one will call me back. And I've talked with Ann Casper, she's had a similar situation. And one of the things I would like to see how we can address this is what's happening with AMR. Are they over-medicating these people? And to the point that when they arrive in ER, they're not breathing. So they've intubated them. And so now they are in ICU until they can get them stabilized and then get them into the psych unit. So I look at going into the psych unit for my son is a point of equilibration where he can kind of gather himself to get past this suicidal ideation that he lives with.
One thing that we've talked about is funding, but the basis for funding for mental health, and you know, I grew up through the Reagan era and the loss of funding for mental health. We need to change our community. Our community basically has let it go. You know, homeless is out here. We're okay over here. But how much does it cost? How much does it really cost to have all of this mental health go unchecked, the problems that they have? It's got to be a ton more than what you would spend if we could get people to vote in, you know, proper mental health programs. And we need, as a community, to get people to change their attitude towards this. And I think that, you know, funding is great, but as long as you're getting that guy to begrudge that dollar that he gives to you, when they can see that there's a rational, reasonable reason for this, then maybe they'll change their mind and fund the programs that we need.
I'm glad to be here as well. I'm Jan Clay. I work for Telecare. I hope one of the outcomes of this process is a shared vision can be created that all Multnomah County folks can rally around to move this system to where we would like it to be, whatever that shared vision looks like. That's what I would hope the outcome would be for this particular process.
Hi, my name is Jiro, Jiro, and I'm kind of alternative service provider. And I just like to address that today's meeting is really intense content. So some people feel, oh, my mental health is much better because of today's meeting. And some people say, oh, today's meeting is so bad. So just like there's probably lots of service providers here and receivers here, and maybe both of them. So just I want to connect these people. Like we just talked about some systems not connected, but here we maybe connect, maybe not connect. Just want to say.
My name is Surasai, and a lot of Americans or English-speaking people mistakenly say suicide. But here's the story, backstories. 1999, I was admitted as mentally ill. And to this day, I can't escape but think about all the people that go through it. I've seen different faces go through the community, have their mania. And it touches me because I've been there. My youngest brother is being admitted now. Now more than ever, he needs his older brother to be a peer-to-peer. And I see that process coming into fruition. And I hope the community listens to what we shared and implement these beautiful processes for the next 5 years so we can create a powerful, loving process to be there for one another. Thank you for sharing all your stories, sharing the food. It's warming to my heart to know that we care.
Well, I feel inspired from this discussion, and I hope others do too. And people have different reactions. So, Jiro, there was a fantastic discussion around reaching out and connecting. I just want to honor, just take a moment to honor the folks who've shared their lived experience tonight. You know, I mentioned at the beginning we're a values-driven organization, and this type of conversation is really the bedrock of what we do. So thank you. All right, so next steps. So this has been awesome, and there's like 15 people who've been taking notes tonight. One thing that we'll be doing is sort of typing up those notes, synthesizing them, and those will be integrated into the final report that we'll deliver. Some other things that'll be happening. I spent the day in rather back-to-back key informant interviews today, and tomorrow and Wednesday morning we'll be doing the same, and then we'll be coming back. The team and I will be continuing to do those interviews over the next 2 months or so with folks. We're also mining existing reports and materials. If folks have my contact information, I'll put up in just a moment. If folks have other data or reports that they think would be relevant and important to share, I'd be really glad to hear from you. We will be reaching out to provider organizations, different departments to see if there are other pieces of data that are available for us to synthesize that might not be publicly available. And then we'll be working very hard in the early part of next year to put together a draft final report, which we will deliver to the county. And then the goal is to have a final report that will be available to the public in early summer of next year. So that's the plan. And here's my email address, and also how you can get in touch with Commissioner Meieran and Shannon Pullen, who are coordinating this project here in the county. So we welcome hearing from you. Really, we do. So do feel free to, feel free to reach out because we'll be glad to hear from you. And I will pass things over to Commissioner Meieran to wrap up.
I'm sort of speechless. I just want to thank you all so much for taking the time to be here tonight and for sharing your stories. It is so meaningful, and it truly does make a difference. I want to, we've heard some fantastic ideas here tonight, and moving ideas into action takes understanding from people across the board, including elected leadership. And I did want to acknowledge some of the exceptional elected leaders that we do have here tonight, that it's great that they were able to hear directly from you. And those are Representative Alyssa Kenny-Geyer, Senators Lou Frederick and Lori Monis Anderson. And we have had staff from the offices of Ron Wyden, Chair Deborah Kafori, Mayor Ted Wheeler, and Commissioner Chloe Udaly. And Earl Blumenauer, sorry. Really all dedicated to this issue and working together at all levels to figure out how to make things happen. So you all have such a depth of knowledge, experience, perspective, and insight. And like I said, this is not the only time to have this kind of conversation. We want to hear from you. If you didn't feel comfortable speaking tonight, or if you have additional ideas, go to the Multnomah County website. We have a place for you to give your input on the website. Contact my office, contact Shannon. And speaking of Shannon, I really do have to say a deep, heartfelt thank you to Shannon and to my incredible staff. Katie Shriver, who doesn't like to be in the spotlight ever and is sitting there glaring at me, and Renee Uzinga and Kyle Schwab, who made this all happen. And they did it beautifully, and along with HSRI for being out here and doing this tremendous work. So thank you again for being here. It is 7:30 and we are done.